By way of a quick show of hands, if you don't mind, are all of you in the room first-time takers? Pretty much, yeah. Okay. And of those, who's nervous about the ECG section? A lot of nervousness out there, yeah. Don't be. Really, don't be. I've been doing this session for as long as I can remember. And the one thing I hear from first-time takers time and time again after the exam is it really wasn't as bad as I thought it was going to be, okay? You've seen all this stuff before. You know this stuff. Really, it's the question of playing the game, the trick of the exam, okay? And I hope within this session we can show you some of the nuances of coding and so on for the exam purposes, and then give you a quick practice session towards the end. This is not an ECG session as such. Again, it's just more of a practice session for you. So with nothing further ado, a couple of points I want to make that are in regards to the exam. Time is an important factor. I would suggest you practice on 3 minutes per ECG and get used to what that time feels like. It's actually a very long time, but it's time that you can waste on nuances and minutiae if you're not careful. I can't emphasize enough how important it is to get used to the electronic form. And I urge you to do the online tutorial so that you familiarize yourself with where everything is. And we're using that format here today, so that should give you some idea of what that is if you haven't seen it already. But I would urge you, when you practice your exams, to look to that electronic format, because there's a lot of time that could be wasted in looking for the specific diagnoses when, if you're used to the format, you know where they are more exactly. As I said, almost all of the ECGs on the exam that you will see are very straightforward. The idea here is for you to show that you can recognize important ECG findings. These are not complex rhythm diagnoses. These are not complex pacemaker type ECGs. They are very bread and butter, fundamental type of ECG examples. From talking to past takers and my own experience from many years ago, there are typically 2 or 3 major findings on any given ECG. I would say that if you're looking to code number 4 and number 5, you're probably overdoing it, okay? So it's the first impression that you'll get in the same way you would do so in the clinical arena that's usually the right one. There's usually something big and then something that may be just associated with that, that again, from clinical practice, you would often be well aware of. It's very uncommon to have multiple different types of rhythm, MI, and other diagnoses on the same ECG. Now, the way that these ECGs are put together for the boards is basically there's 20 people who come together and bring their favorite ECGs, and the board adjudicates them. And sometimes there are people that are more influential or more persuasive than others, and they get their little pet ECGs put on the board exam to be reviewed. And if that ECG is one of those complex minutiae type examination results, it won't probably appear in the marking system. So also be aware of the fact that if you're really struggling over a particular ECG and you really can't figure it out, don't waste the time, move on, because that ECG may not actually figure in the scoring system itself, okay? And the one thing you really don't want to do is reach the end of the examination and find that you've got several ECGs still yet to be coded. Keep it moving. Think of that 3-minute window in your mind. And with that, and I'll say this several times in this session, and I make no apologies for saying it, don't overcode. Don't overcode. Because that's how you lose marks. Okay? So it's important not to overcode. In chatting to people who take the exam, and indeed former members of the ABIM who put the exam together, what you'll find for the examination is typically 37 to 39 ECGs within a 2-hour period. The electronic format was introduced a few years ago, and many people have said it's a little bit confusing, which is why I'm emphasizing familiarity with it before you take the examination. It can be difficult to navigate some of the tabs and so on and so forth, and to know where some of the different diagnoses are. The other thing that I suspect you won't use very often, but perhaps you might in certain situations, is the calipers. The calipers that are, at least last year and the year previous to that and before, are a little bit tricky. So again, practice that tutorial and get used to using the calipers. Again, you probably won't use them so much, but you don't want to waste time trying to figure out how the calipers work. What the ABIM say is really reinforcing what I've just said previously, that this is not an exercise in identifying minutiae of clinically unimportant details. It's to determine that you know the big stuff, the important stuff that's going to be important in terms of managing patients with cardiac problems, okay? So they'll want to know that you can recognize an MI, that you can recognize that this WPW, for example, is not an acute myocardial infarction. There'll be situations where typically the most important is weighted towards diagnoses where you might change the management of a patient. In other words, you may miss certain diagnoses and offer an alternative therapy for that patient that's wrong. And that's where the board are going to weigh in heavily on the importance and accuracy of coding. In the scoring system, many people have questions about this. It's one of those things that comes up annually in regards to the boards. How do they do the points for the different codes? And there's some weighting to it. And I think I'll be honest. I've thought I understood this previously, and I'm not sure I do necessarily, because I think it changes from ECG to ECG. And these are things that the committee that put these tests together adjudicate beforehand. But generally speaking, if you look at how they do the point system, they'll typically have 1 to 4 points for a correct answer. You won't get any points if it's a very equivocal answer, and you may actually lose points for incorrect answers that affect the management of that patient. Like I said, if you say something that's clearly incongruous with what you've just previously coded, that's when you start to lose points, get negative points, and obviously are not obviously you don't want to do that. Other examples that come up time and time again are question, what if I code left anterior fascicular block versus left axis deviation and so on and so forth? I really would de-emphasize those kinds of things. I really would. There's not a lot of difference between left axis deviation and left anterior fascicular block, okay, in terms of the boards now. I mean, people don't die of left anterior fascicular block, at least that I'm not aware of. And so they're the kind of things that the board will probably see as a very subtle, soft point. And if you're sweating the details about left axis deviation and left anterior fascicular block, you're not going to get much gain out of it because it's not really something that the board focus on. This is the layout of the coding sheet, if you will. That's the electronic coding sheet. This is the one that the boards use. And actually, I have here several sort of times here on this web link here, the direct access to this tutorial. So if you click on that, you'll get access to the ABIM tutorial. And on that is this coding sheet, and you can practice with that. And as I say, get used to that format where everything is. It's very similar to the paper format that we had before, but there are a few subtle changes that I'll talk about in a short while. One of which that come up as a bit of confusion last year is this Q-wave versus non-Q-wave kind of thing. The board in their scoring system actually moved away from use of the term Q-wave, but as I'll go on to explain a little bit later, it's actually probably a good thing for you to keep in your mind when you're coding these things in terms of myocardial infarction, because there are differences that are important in terms of the way the boards are looking at these things and not. But beyond that change here, where they removed Q-wave and non-Q-wave, there aren't too many changes from the electronic format to the paper format. Here's the tutorial, and again, I suggest you review this, get used to it, where the different tabs are for different things. This is how you'd mark a ECG for review that you want to come back to later, that you're not sure about. And again, I urge you to keep moving and don't spend or waste too much time on any one particular ECG. And also know that you have to sometimes highlight here to pick up the figures. So if you highlight that, you'll see the ECG that you are being asked to code. All of the ECGs will have some banner with it, 50-year-old with chest pain or 45-year-old on dialysis, that kind of thing. They often are helpful, so read them. They do often give you some clues, at least to the clinical aspect of things. And so don't ignore that little banner, because it's there to sort of give you some context for the ECG, and they will all have that. You know this from your clinical work. Be systematic, and more so be systematic about how you review ECGs on the boards and try to get into a pattern. I don't think it necessarily needs to be as complicated as this. This is, a very systematic sort of approach. But if you get used to going through the ECG from the top left-hand corner down to the bottom right-hand corner and then across the precordial leads, you'll typically cover pretty much everything in that review. And that's certainly when I look at an ECG for the first time, that's where my eyes go. I look at the top left-hand corner. I want to know one AVL. I want to know what the P wave vector is. I want to know what the rhythm is, and so on and so forth. And I'll work my way down across all the leads and utilize all the information that I have there. But be systematic if you can. And then, quick check. A common thing would be inferior wall myocardial infarction and some sort of Mobitz block. You see that now perhaps less so clinically than you would do maybe 10 years ago before primary PCI. But they're the kind of things that are good associations on the board. We know it happens. There's a clinical reason for it. It's frequent enough that those two things come together. So whenever I see an inferior wall infarct or ST elevation, I'm looking to see what the rhythm is. And if there's group beating of some sort, I'm going to code Mobitz 2 as well. All right. So they're the kind of things that the boards will, I think, most reasonably put together as a coding pair, if you will. So let's just go over a few coding dilemmas, and then we'll get on to the practice test. So what comes up now, again, I mentioned that the boards aren't using Q waves so much in their coding sheet, but I think it's important for you to keep in mind that there is a difference, okay? So when you see Q waves in certain leads, then take note of that, because that's going to determine whether you're going to call this an infarct or whether you're going to call it an injury pattern. But one thing that comes up quite frequently is you see Q waves in V1 and V2, should you code an anteroseptal MI? For the boards, probably not. And they won't give you necessarily something where it's equivocal, but you may just see a Q wave in V1, and then you're going to code an anteroseptal infarct? No, you're not. But typically, you would require a Q wave in V1 through V3 to code for an anteroseptal infarct. Here's some of the data that is based on, and you can see that it's very old. I mean, 1978 and 1989, several of you, I'm sure, weren't born then. And you can also imagine how the people that write the boards or give the ECGs for these are pretty old too, with a lot of gray hair going on. And so a lot of these types of things are still there in terms of the philosophy, if you will, in terms of the coding approach. Again, this sort of stuff is not new to you, but just keep it in mind to review it before you do the exam. Make sure you know what a pathological Q wave is. It's at least 20 milliseconds in the precordial leads and 30 milliseconds with 1 millimeter depth in the other leads. For a posterior or true posterior infarct, you want at least a 40 millisecond R wave and an RS that's great, or R that's greater than S, with T wave inversion for those leads. And you also want a Q at least in 2 contiguous leads. Just an isolated lead, especially in the inferior leads, doesn't count. Okay, another problem. So the ECG shows an acute myocardial infarction. So you see Q waves. The question is, should other ECG diagnoses be coded? Well, certainly you want to code the rhythm and or the AV block, Mobitz 1 type of thing. But this type of thing comes up very frequently. Well, should we code ischemia as well? I would say no. If you're going to code a myocardial infarction, the implication is that there's ischemia, okay? And so when you start to code myocardial injury and you start to code T waves suggesting ischemia, you're overcoding, okay? So I would, if you see Q wave myocardial infarction, code that and look for the other stuff. You're done, if you will, with the ischemic part of that. You don't need to code injury. You don't need to code ST wave changes and so on. What about left bundle branch block? If you see an ECG with left bundle branch block, should we code myocardial infarction? I would say no. I mean, we all know the criteria for that, but the boards aren't going to ask you that sort of stuff. And so you're going to see a pattern perhaps like this, and I would code injury, since there are no Q waves. And again, that's my point for saying, think of Q waves in your mind, because it helps in the interpretation, even though the boards aren't actually asking you for a Q wave diagnosis or not. So here I would code injury and not infarction. Again, with acute myocardial infarction, ST depression and or reciprocal changes, the question then comes up, well, should we code ischemia? And the same thing applies, as I said before. If you code a myocardial infarction, ischemia is implied. Clinically, you may say something differently because it helps in the management of that patient. But for the purposes of the ECG boards, I wouldn't code ischemia when you've clearly seen an acute Q-wave myocardial infarction. Again, another important problem that we've touched on already, ST elevation but no Q waves. This is an injury pattern. So I would code injury here. And even though the form on the electronic test doesn't actually say Q waves, they talk about age and they talk about myocardial infarction, okay? And so when they're talking about myocardial infarction, they're talking about a Q wave present. When they're talking about injury, there's no Q wave, but there's ST elevation, okay? If there's ST depression and you've coded myocardial infarction, don't code them both. That's my advice. LVH, I've said this before and I'll say it again. When you see left ventricular hypertrophy on an ECG that's on the board exams, it will jump out of the screen at you. You know, if you can't see that hypertrophy, you need to do something else. You know, you won't be measuring millimeters of criteria, okay? So you're going to see, you know, a patient with sort of apical HCM or some sort of humongous amount of LVH, and it's not going to be subtle. But I've just put here anyway, just for your review, those criteria, which are worthwhile just having a quick look at before the test, because it's just the kind of thing, and I forget this all the time. I mean, and I do this thing every day, you know, but it's one of these things that the numbers are difficult to keep in your head. But the boards, they're not subtle about this. And if you're scratching your head thinking, I'm not sure if there's LVH there or not, there probably isn't. Which ones to use best? Well, it's like most things in life. I use the ones that I can actually remember, and they seem to serve me well. And I'm a favorite of the Cornell criteria, but Sokolov are also fairly easy to remember. And again, just review the numbers, but it's going to be, you know, sort of out of this world hypertrophy. It's not going to be subtle. So don't sweat the details on this one too much. RVH, again, this is going to come up where I've typically seen the key or the banner, you know, suggesting RVH before you even look at the ECG. You know, it'd be sort of, you know, 27-year-old female with pulmonary hypertension. And you look down and you go, oh, yeah, that's RVH. Okay? So they do actually give you some criteria, and frequently with that, you'll see that the two correlate, and you can make that thing. But what would we use? Well, right axis deviation, of course, you've got to have that present for significant RVH. With an R wave greater than S in V1 and V2 with these sort of secondary RVH type of changes. You may see some P pulmonale, or, you know, the P wave in typically lead 2 being more than 2.5 millimeters or so. The ones I've seen in the congenital lectures, they call it Himalayan P waves. They're stonkers. And you're not measuring like, could it be 2.5 or 3 millimeters? It's like that. And so that's the kind of thing you'll see on the RVH side of things. You'll see very, very obvious findings. So this sometimes comes up. So you see a junctional or a ventricular arrhythmia present, and the question I've been asked several times, well, should you code the atrial rhythm? Of course you should. Yeah, you should code both chambers, what's happening in the ventricles and what's happening in the atrium. You may not see what's happening in the atrium if the QRS and the P waves are fused, of course, in which case you can't say anything about them, but have a careful look. And if there's any variability in the rate, this is one of the keys to these types of things, look across the whole ECG first. And I would actually say that's the way you approach every ECG in the exam. There's a sort of head-down focus approach that people take when they do exams. The head's down, they're not looking at the big picture because they're focusing on different areas. I would say, look at the ECG at arm's length, or at least at focal length first, get a gestalt for what the whole thing is and looks like, and then sort of hone down on sort of things that seem to be abnormal. And one of the first things you see as an arrhythmologist, if you will, is irregularity of the QRS complex. So if you see there's QRS complexes and there's some irregularity to them, that's probably where the money is. So go and take a look and see if you can see something that will give you any clues to what might be going on there. But code what's happening in the atrium. And again, what used to be in my head was I'd say, right, what's happening in the atrium, what's happening in the ventricles, and what's happening in between, okay? And keep that sort of thing in mind because it can be easy to sort of see, as the example I gave before, a humongous inferior wall MI and then miss out the AV junctional Mobitz 1. But code the atrium, code the ventricles. Don't miss anything out. Again, this is the one that comes up very frequently, and again, I tell you not to sweat this at all. Should the axis be coded when there's left anterior fascicular block or left posterior fascicular block? The fact is, they're not exactly the same, and they're not exactly mutually exclusive, but they point to the sort of a similar process. And again, nobody ever died that I'm aware of left anterior fascicular block, and so it's not such an important thing. And you wouldn't believe the anxiety that I've heard from people about just this, honestly. And it's all wasted because it's really going to count for like a whiff of a half of a point, okay? I tend to think of it as this, where, if there's some pathology, like LVH, then I'll talk about axis, if it's shifted. If there's some pathology like conduction stuff, then I'll go with the fascicular block, because we're talking about the similar pathology. But that's still pretty subtle for what I think the boards would ask you to do. The fact that you can see the axis is abnormal, you're doing good, okay? And I think you're going to get the points for that. And if you're so hot that you sort of say, well, I know this is left anterior fascicular block and I know this, great. You might make one more point than the person next to you that doesn't know that. But I've seen people waste, a lot of time on these kind of things, and it really, in the grand scheme of things, is not a big deal. So try to avoid that if you can. Here's one that comes up time and time and time again. And if you don't see a WPW on the boards, then that'll be the first year in as long as I can remember. I mean, it really will. I mean, it comes up every time. And what they want you to do is they want you to miss the fact that there's WPW there, and they want you to code some other pathology. I would say if you see sinus rhythm and a short PR interval and what you think is a delta wave, call it WPW and sinus rhythm and move on, okay? Don't start to second guess that there could be something else going on there, because you're going to be wrong. Because remember, with an accessory pathway, which is what WPW is, you're going to get abnormal ventricular depolarization. And so everything's going to be off, okay? And this comes up all the time. And I would even go as far to say that this is one of the areas that people have failed the boards on. Because imagine if you see an infarct and you call it WPW, or see WPW and you call it an infarct, there's there's a decision tree there that's completely and utterly diametrically opposite. In one, you take to the cath lab or give thrombolysis, and the other, you reassure and you send off to your friendly electrophysiologist. Completely different management, okay? And that's what the board will focus on. And this comes up every time, and I guarantee there'll be some takers of the boards who haven't been to this lecture who will make that mistake. So watch out for that one. It comes up every year. The other one that comes up from time to time that people fret about, both on the boards and clinically, if I'm honest, is, well, it looks like fib over here, but it kind of looks like flutter over there, and what should I code? You know, it's all fib. Just code fib. You know, even organized fib is fib. It's not flutter. Yeah? I mean, you've seen the isthmus-dependent, you know, sort of right atrial flutters, of course, clinically. That's flutter. And that's the only one they're actually going to ever give you that is worthwhile coding as a separate thing. Anything else is fib, yeah? And of course, that's more common anyway. So that's what you're going to see on the board. So don't code the two of them together. You know, here you could sort of say, well, there's a little bit of organization there. This kind of looks like this. But this is not a sawtooth thing. You know, this is not CTI-dependent flutter or cavo-tricuspid isthmus-dependent flutter. This is just a kind of a lot of fib. And that's what you should code it as. Don't code both. You know, if you coded flutter for this, would you fail? No. I mean, you might not get 4 points. You might get 1 point or 2 points, but you wouldn't get negative points. I mean, you wouldn't be completely wrong. But the thing to do is not to code them both, and that almost everything outside of that very clear sawtooth pattern that you'll see both clinically and on the boards is fibrillation and not flutter. Again, don't code them out. Okay, so that's the first part of the lecture over. And I want to move on to sort of giving you a little bit of practice. And this is the first year that we've used the portal for you to practice on that. And as Jeff Geske was pointing out before, you should all have that up and loaded in front of you, and you should have the same slides as you have here. And the advantage of doing it this way this year and in the future is that it more mimics how the process will be in the exam, because of course it will be an electronic format and not a paper format, which is what we've done before. So the way we'll do this is I'm going to show you an ECG. You're going to then code what you think that ECG shows, and then we're going to review things, and we'll just sort of go through, you know, what I might code this as, and compare that to yourselves, what you might code that as. Now, I think we'll, instead of taking the full 3 minutes, take 2 minutes in this test. So keep in mind that in the board you'll have 1 more minute to review things. But that'll just give us a little bit of time if we have any questions about any of the ECGs, just to review them and discuss. So here is the first ECG. So here's what I thought, and again, this is what I thought. This is not necessarily absolutely the correct answer, but I thought sinus bradycardia, anterolateral MI, old, inferior MI, old. I wouldn't add left axis deviation, and posterior MI, old. I wouldn't do anything with the SDT wave changes suggesting myocardial ischemia. So that's what I thought for this one. Here's the inferior, posterior, and anterolateral MI present. And that's that. Okay, this is number 2. So here's an example where the banner actually helps. There's some symptoms that could be suggestive. Here's how I would code it. So sinus rhythm and ventricular, or a PVC, ventricular escape rhythm, and third degree AV block. So here's the ECG. You can see sinus here. It's upright in 2-3. AVF, negative in AVR, so it's sinus. Sinus often has a notching in the P wave in the lead 2 as well. It gives it away. And we see that the sinus rate is faster than the ventricular rate. So there's a faster A than V. If it was the other way around, that would be AV dissociation, right? In other words, the V was going faster than the A, you may see AV dissociation. It's not block. But here, if you measure that interval from here to here and from here to here, it's clearly longer than that interval from there to there. So this is heart block. It's a PVC-looking escape rhythm, so it's a ventricular escape rhythm. If it was narrow, you might call it a junctional escape, but we'll call it a ventricular escape rhythm. And here you see irregularity, and like I was saying earlier, always look for some irregularity in that strip as you view the whole ECG. And the morphology of this looks different to that one. And so this is a PVC coming in early. So that's the kind of thing they might just throw in for you. All right. Let's do this one, shall we? All right. So, VT and AV dissociation. There's a lot of discussion about these kinds of things. Is it SVT with aberrancy? Is it VT? The fellows that are here at Mayo will know this because I talk about it ad nauseum. But try to think about wide complex tachycardia versus narrow complex tachycardia, okay? No one can say that you're wrong if you call a rhythm that has a wide QRS complex and this has a rate greater than 100, okay? It's nothing, you can argue with that one. And so instead of jumping to the diagnosis of VT or SVT with aberrancy, clinically and on the boards, think wide complex, narrow complex. And this is a wide complex rhythm because the QRS duration is greater than 120 milliseconds. And then what I would do is sort of look at the morphology. And here you have this sort of atypical right bundle looking thing in V1. And keep in mind that if you're talking about or you're going to diagnose some form of SVT with aberrancy, then the morphology of the QRS complex in lead V1 has to look like a right bundle or it has to look like a left bundle, okay? VT doesn't care about the morphology. The only thing that determines the morphology of the Y complex rhythm is the exit site for where that reentrant circuit is, okay? And in general, if the exit site is from the right ventricle or the septum, the interventricular septum, then the morphology in lead V1 would be a sort of QS pattern. So it looked like a left bundle type pattern. Or if you think about it this way, if you were to pace the right ventricle, you get a left bundle type of appearance in lead V1. Well, it's the same process as happening with VT. You're activating the ventricle on the right side first, so the morphology in lead V1 looks like a QS pattern as if you were pacing from that side. And if you were pacing from the left ventricle, or the VT was exiting from the left ventricle, then it would be a right bundle morphology. So this is a VT, or a wide complex tachycardia, that's coming from the left ventricle because it's got a right bundleoid morphology. And again, I'm using this oid. It doesn't look like a right bundle. It doesn't look like a left bundle. It's got an R in V1. And this is also a inferior axis and a very basal type rhythm. The other things you can look at are sort of capture and fusion beats and concordance. Concordance is a very important thing to look for. What that basically means is that in the precordial leads, all the QRS complexes are pointing in the same direction. And the important thing to note is which way the pointy bit is, okay? See here, of the curious complex, the pointy bit is upward. So this is positive concordance. If the pointy bit was downwards, that would be negative concordance, okay? And what's important to know is that if you have negative concordance in the curious complex, so all the pointy bits are down, then the only place that that can come from is the apex of the heart, okay? Because all the curious complexes are going away from V5, V6 because of the negative concordance. So it can't be, in any way, shape, or form, supraventricular. I mean, if an ECG tech hooked up a patient in such a way that they could get negative concordance to be supraventricular, I'd want to meet that person because it would be a pretty difficult thing to do, I think. Very innovative indeed. So anyway, VT. As I said, you know what a right bundle looks like. You know what a left bundle looks like. If you're going to say supraventricular with aberrancy, make sure that the leads look exactly like this, okay? Because that's really what you're saying. You're saying there is some supraventricular mechanism conducting aberrantly down the right or the left bundle. Anything else that doesn't look exactly like this, down to the rabbit ears being up here and down there, is VT, okay? So don't be fooled into thinking something else. And here you've got this atypical right bundle. Again, the rabbit ears here are higher on the left side than the right side. And so this is not right bundle branch block rhythm, this is VT. Yeah, it's just saying that, you know, if you measure the curious width, I mean, the wider it is, the more likely it is to be VT, and that's what all those criteria are based on. Another tip for those of you that are not electrophysiologists, don't bother reading all the criteria, they just drive you nuts, okay? If you stick to what I just told you, looks like a right bundle, looks like a left bundle, positive, negative concordance, and obviously fusion complexes and capture beats, you know, you don't need any of these criteria. You don't need any of these criteria. All right, so here's the next one, 1D. 86-year-old man with dyspnea. Okay, so this is what I thought. This is MAT, and I think you could be. I think you could say this is acute cor pulmonale with possible pulmonary embolus. If you didn't get that, I think that most of the marks would be for the rhythm diagnosis. And there's nothing diagnostic about this ECG that says it's a pulmonary embolus. But again, just in terms of thinking about what the clinical diagnosis might be, you'd probably get an extra point or so for that extra thing. But for the MAT, that's where you get the lion's share of the marks. And we have at least 3 P waves morphology. So this one is different to this one, which is different to this one. And the rates are greater than 100. If it was less than 100, it'd be the wandering atrial pacemaker. But this is multifocal atrial tachycardia. Another frequent appearance, honestly, on the boards. It's more of an internal medicine kind of thing, I would have to say, but it turns up on the boards quite a bit. Okay, what about this one? 44-year-old man with dyspnea. Let's take a crack at that and see what you think. Okay. So here's what I thought. sinus tachycardia, third-degree AV block, anterior or anteroseptal MI acute. So here's our atrial activity, and here's our regular Curis complex that's slower than the atrial activity. So there's block and acute anterior MI with ST elevation. Sorry, junctional, what? No, I wouldn't call it junctional. I wouldn't call it junctional. I see what you say when you call it junctional. Oh, you mean junctional escape, you mean? Or yeah, you could say junctional escape. I think that's reasonable. But I wouldn't call it necessarily a junctional rhythm. But yeah, you could call it a junctional escape, I guess. It's pretty fast, so I'd probably just say a junctional rhythm. AV dissociation, no. I won't ask who asked that question because I can't see it, but no, because the P wave activity, the atrial activity, is faster than the ventricular activation or activity. Okay, and AV dissociation is a bit like those really old films, you know, where you used to sort of see the carriage wheels, the spokes of the wheels appearing to go backwards. It's because they're out of sync. So you've got the lower chamber firing faster than the upper chamber, which can't catch up. So it's dissociated. Yeah. Here, this is a bit like lobbing tennis balls over the tennis net and each one getting stuck in the net. It gets blocked. Okay. So they're coming out of the sinus node or the atrial activity, but they're not conducting down. Okay. So the rate's faster in the atrium than in the ventricles, and there's no perturbation or change in the rate of the ventricular activity. It's rock solid, stable, okay? This is what you also see in AFib when AFib becomes regular. You've got AFib and the Curis complex become regular, it's heart block, or DIG toxicity was the other one. That comes up on boards quite frequently too. You probably heard about that on the EP section. Okay. All right, moving on. Here's a 74-year-old female with a fall and hip fracture. I'll also say that I think for those of you that may be wondering about the level of these, I think these are harder than you'll see on the boards. The examples I'm showing. I'm showing you to try to bring out a few points to try and make for you to help, but I think they're actually a harder diagnostic ECGs than actually appear on the boards. Okay, so this is a hard one if you hadn't seen it before, but again, that's what you're here to see some of these things. So I coded this out as sinus rhythm, and ST T-wave change is considered consistent with electrolyte abnormality and QT prolongation, and the clinical problem is hypocalcemia. So this is a very classic appearance of hypocalcemia. And I wouldn't be surprised if you see an example of this on the boards. The other thing about boards is that the sort of things that you see very frequently on the boards that you never see in clinical practice. It's just the way these things happen. But the important thing about this is that the QT interval is prolonged, but it's actually the ST segment that's very prolonged. And it's sort of been described as a sort of a plane and then a Himalayan kind of mountain appearance. You know, it sort of just arises up from that. Very similar to long QT3, actually. But here you've got this fall, you've got a hip fracture, you know, be thinking some sort of calcium thing, and that's what it is. This is hypocalcemia, and again, I wouldn't be at all surprised if this comes up on the boards, and then you never see it again in the rest of your life. All right. Oh, here we go, an Axis boy. Sorry. Yes, you could code left axis, yeah. But the big thing is here. Yeah. All right. Here's another one. 16-year-old female on treatment for palpitations. And again, I think these banner titles are fairly typical of the kind of thing that you see. I mean, they're not going to say, 40-year-old, 50-year-old male with multiple risk factors for coronary disease having crushing central chest pain. I think I'm having an MI. They're going to be a little bit like this, and the people who put these ECGs together think they have a sense of humor sometimes, and they think they're being clever. But take note of the banner. That's really my point. Look at it and sort of see what could this be that is consistent with that, and what are they trying to ask me here? Okay, so here's how I read this out. I think sinus bradycardia. Watch out for those things too. It's very easy to miss sinus tachycardia and sinus bradycardia. Get used in your mind to sort of looking at the number of squares and sort of a quick gestalt. Does this look really slow or does this look really fast? Again, you're not going to lose big time points on any of that, but obviously you want to get all the points you can. And if you say sinus rhythm, you might get 1 point. If you say sinus bradycardia, you get 2 points. So it's just a little bit worthwhile looking out for that. Anyway, the main thing about this, of course, is the humongously long QT interval, and they wouldn't want you to miss that. The other thing I often say with these kind of types of examples is that the QT interval is where they might get you. In other words, you're looking at an ECG and you think, this looks normal to me. I don't see any major abnormalities. Don't forget the QT interval. Don't forget the QT interval. And especially that one that I showed you just previous that looks like the hypocalcemia. That can look very like long QT3. So just kind of keep that in mind. Don't forget the QT interval in apparently normal looking ECG. All right. Let's move on. So, 21-year-old woman with palpitations. Okay. This is what I coded. AFib and WPW pattern. This ECG is about as guaranteed to come up on the boards as, I don't know, sun up tomorrow. Every year this comes up. And it's one that if you haven't seen it, it's very confusing. And I urge you to sort of look at this, internalize it, and expect it to come up. Okay? Because it will. The main sort of features about it are it's just bizarre looking. Yeah? And it's irregular. And it's a young person, and you're not told they have any structural heart disease. And you can sort of see subtleties like this. I think when they show it to you on the boards, it'll be even slightly more obvious than this. But it will almost certainly, definitely come up. And the reason for that is that you could erroneously diagnose this and give the wrong treatment. and there could be bad problems. So the thing you don't do with this situation is you don't give adenosine or anything else that blocks the AV node. There's a misconception out there amongst some, probably not anybody in this room, but I'll mention it anyway, is that if you have a patient who presents with a narrow complex tachycardia and you know that they have Wolff-Parkinson-White, the misconception is you can't give an AV nodal blocking drug. You can, and you should, if the rhythm is a narrow Curious complex, because then activation of the ventricles is down the normal conduction system and back up an accessory pathway. And you give adenosine and it terminates in the AV node and the rhythm's gone, okay? With this situation, you've got AFib going on, and you've got some parts of the activation going down the normal conduction system and some parts of the activation going down the accessory pathway, and infinite variability in between. And if you give an AV nodal blocking agent, even adenosine that only lasts for a short time, you will facilitate one-to-one atrial fibrillation that becomes ventricular fibrillation, okay? So you take a not stable but not unstable situation and you give a drug like adenosine and you make it into a very unstable situation. You can convert AFib into VFib, okay? So the rule is, if they have a narrow Curious complex tachycardia, you don't care about the WPW thing. You'll see that when they convert. But if it's wide Curious complex, don't give adenosine. So pre-excited AFib, you'll see that. Okay. Here's another one. 88-year-old woman with dyspnea. Okay, so this is what I thought. Sinus tachycardia, AV block 2-to-1, left bundle branch block complete, and ST and/or T wave of injury. So, yeah, so again, this is the obvious finding, the injury pattern. That's what all the marks are going to be for, but the underlying AV conduction is also important, and it's very easy to sort of miss that kind of P wave sort of buried in there. Look at all the leads. Don't just focus on one lead, because you may see activity better in one lead versus another, and use all the information you've got to be able to say what it is. But anyway, that's what I would code that out as. All right, moving on. 87-year-old woman, routine ECG. So the implication is that the patient's asymptomatic, at least for the purpose of the boards. But okay. So here's how I read this out. AFib, anterior, or you could say anterior septal MI old, inferior MI old, and one of the subtle findings was pacemaker malfunction, not constantly sensing. Now, so I don't think anyone have a problem with the AFib. If somebody said flutter, that's fine, not a big deal. But I would say fib for the most part. I think most people would be fine with the inferior and anterior infarct. But this is the kind of thing that, they just like to throw in sometimes. And that's why I was sort of saying, look at all the leads. Don't get used to scanning the whole thing. And try not to miss something like that. It's you could say, well, is this failure to capture? Because it's not capturing anything. Well, no, because it's in the T wave. and you wouldn't expect the myocardium to be ready to be stimulated so soon after it just been depolarized. And so the fact is that this complex here is not sensed, and so the pacemaker delivers a spike there, and of course nothing happens. But you see the clear capture of the ventricle there with the pacemaker, which makes this not some sort of artifact, which of course it could be in clinical terms. So watch out for those kind of things. This is ventricular pacemaker. I don't know if it's VVI or not. I can't say from this particular tracing what the programming of the pacemaker is. But it's a ventricular pacemaker that didn't sense that previous QRS complex. Okay, moving on. 47-year-old woman with routine ECG. Again, the assumption is that they're asymptomatic or maybe preoperative. So let's see what we think of this. Okay, so I think sinus rhythm, right axis deviation. This is an RVH type situation. And the right atrial enlargement, it's not Himalayan, so I wouldn't necessarily code that. This is probably someone with pulmonary hypertension of some sort. The quick check here, because sometimes when you see this sort of reversed R wave progression, is could this be dextrocardia? Look at 1 and AVR. If it's dextrocardia, AVR is positive, as in the P wave is positive in AVR because the vectors are switched. Same for 1. So here the P wave is going from the right shoulder down towards the left foot. Okay, so it's not dextrocardia. And then you couple that with the large R wave in V1 and the right axis deviation, it's right ventricular hypertrophy. But when you first look at this, you could be forgiven that this could be dextrocardia when in fact it's not. Okay. So here's the next one. 53-year-old man on dialysis. Alarm bells. What could that possibly be? I've never actually, while I'm thinking of it, never actually heard over all the years of an example where the boards were deliberately trying to mislead you. That's the other thing. They may be very vague, but they won't deliberately try to mislead you. So if something's incongruous in terms of the banner and your interpretation, suspect that maybe you should revise your interpretation. Because they don't generally, at least that I've never heard of, try to deliberately give you some false information to lead you astray. Okay. So sinus rhythm, ST wave changes consistent with electrolyte abnormality. I think there's hyperkalemia. There's not humongous LVH, so I wouldn't code left ventricular hypertrophy, and I wouldn't do the ST wave. If you coded ST wave changes of electrolyte abnormality, then don't overcode by saying it's ischemia too. These are the peak T waves that are described of hyperkalemia. Basically what happens with hyperkalemia as it gets progressive is the T waves go up and the P waves go down, and then the QRS complex starts to stretch. And it goes into a sinus rhythm and then ultimately death. And the opposite happens with hypokalemia, okay? The P waves get slightly bigger and the T waves flatten So it's a kind of seesaw thing. So here we're seeing the T waves up, and this would be consistent with the potassium around that shown there. But with a greater rate of change or increase in potassium, you'd see then the P waves disappear, the T waves got wider, and then the Curis complex starting to widen out. And that'd be severe hyperkalemia. All right, let's move on. 72-year-old man with nausea and dyspnea. Okay, so I read this out as sinus rhythm, second degree AV block, Mobitz 1, and acute inferior MI. And this is an example of what I was talking about earlier. It's the kind of association that you might expect in this situation. And whenever you see this sort of group beating, so you see a series here, a series there, and a series there, there's some form of conduction going on, and it's usually second degree Wenckebach type conduction. And obviously, you see the ST elevation consistent with the inferior MI. So this is a very classic type of ECG that was very much likely to be on board. It's the kind of bread and butter kind of stuff. All right. Let's move on. 37-year-old man with dyspnea and a murmur. Okay. I think this is a hard one, actually. But I code it out as sinus, right axis deviation, right ventricular hypertrophy, and SDT wave secondary to that, to the hypertrophy. This is a secundum ASD. There's no coding for that on the board, so they wouldn't expect a clinical diagnosis for that, and you could say this would be very similar to the previous one I showed you that was pulmonary hypertension, because the same forces and so on are at play. But what's just interesting about this is this notching that's oftentimes seen with ASDs that actually used to be part of the board coding. They took it off because it was so difficult to be certain that, or it lacked specificity, but it is a fairly characteristic finding of that type of condition, and that's what this was. Okay, we're on the home stretch. So here's an 84-year-old woman with lightheadedness. Okay, so I code this out as PSVT and left ventricular hypertrophy. I think for those of you that missed that one, would I call it flutter with what? No, I wouldn't actually, since it's not. It's, no, you could be forgiven for thinking that, I think, especially with the age. I mean, it makes sense that it is. But if you sort of look at, I mean, there's a thing really that I've said before that people get into called P-way preoccupation. And it's this sort of sense of like, you know, there's this big thing going on and you're looking at the P waves and making humongous sort of predictions and mileage out of what the P waves are doing. But if you really look at this, take the bottom strip, for example, you can see some little ditzel here that's sort of in the T wave. And fact is, physiologically, or in this case, electrophysiologically, if something perturbs the normal vector of directionality, and what I mean by that is the depolarization in the heart goes one way, and then it comes back the other way. And if there's something that disturbs that isn't going that way and then coming back this way, there's something else there. And if you look at this here, you ask yourself, well, what else could that be? Well, atrial activity is the only thing that could be acting independently of a depolarized ventricle, because the ventricle's already taken up being activated. And then you look at this and you say, well, you know, if I'm going to march this out, I see this here, and I see this here, and I see this here, I should see something about here. And I'm not seeing that. And moreover, the RP interval is fixed. Okay? It's the same. And if you take your calipers out, or if you don't have those, a little piece of paper that we all use, I'm embarrassed to say I don't carry a caliper either, you'll see that the RP interval is fixed. And the only way the RP interval can be fixed is if you have some connection between the ventricles and the atrium. It could be an accessory pathway, or in this case, it could be a fast pathway. This is AV node reentry, which is the most common PSVT. What you have is you've got slow pathway conduction antegradally, and then it comes back up the fast pathway. And you see this fairly short RP interval, which is oftentimes termed the R prime, because it looks like a little right bundle thing. But for the flutter question, I'd expect to see something here and here and here, and I'm not seeing that. So this is AV node reentry. Okay. So again, just to make the point, you know, scan all the leads. Here you can see it quite clearly there. And what I mean is this should go straight, but there's a little nipple here that sort of sprouts out there. That's electrophysiologically a signature of something else being there. In this case, it's the atrial activity. Okay, next one. 84-year-old woman with syncope. Okay, so I read this out as sinus rhythm and second degree type 2 AV block, right bundlar branch block complete, anterior or anteroseptal MI, acute, and I probably wouldn't code anything else such as left atrial abnormality or that. So here we have the sinus rhythm. And we can see that there's no change in the PR interval before the drop beat, which is this beat here, and the cycle repeats itself here. So this is likely the cause of this woman's syncope. But then, of course, we also have these changes here in the anterior precordial leads, which are consistent with a acute MI. You know, if you didn't code the right bundle and you didn't code the axis as being negative, I don't think you'd lose a lot of points, honestly. The big things are the MI and the AV block, because they're really the things that are going to drive the clinical picture in this case. So there we have it. All right. 63-year-old woman with chest pain. So this is flutter, and this is 2-to-1 AV block. You could say 2-to-1 AV conduction. It doesn't really matter too much. But to your point, so this is the thing I was talking about before, where you can see something buried in here and something here. And if you look even up here, there's clearly something that changes the directionality of that ST segment there. That's clearly something in there. And if you measure these out, they march out to a flutter. And keep in mind, what a flutter is. It's a circuit. It's a fixed circuit. And the cycle length or the rate of the flutter is determined by how big the circuit is. And it just so happens that with humans, we have a right atrium that it takes 150 milliseconds to go around. And so that's why we get that 300 rate. And with 2-to-1 conduction, the rate's 150, and 4-to-1, it's 75. That's just a reflection of the size of the circuit. Now, in the era of ablation, where we're creating more circuits in different parts of the heart, particularly the left atrium, it's quite possible that clinically you'll see all sorts of flutters that look nothing like that sawtooth isthmus-dependent flutter because they've been created by the ablation or surgery or something else like that. And it's important clinically to know that if you see a patient who you think has a flutter, if it's not the sawtooth appearance, in other words, that very clear and very characteristic appearance, if it's not that, and the patient's not had cardiac surgery affecting the left side, so no mitral valve, no maze kind of thing, and they've never had an ablation, and they don't have congenital heart disease, that's almost certainly not a flutter, okay? Because there's no circuit in the left atrium before you create one. The left atrium is a very smooth structure, and it can't support a flutter. The right atrium, on the other hand, has lots of architecture in it, the eustachian ridge, the tricuspid valve, the coronary sinus, and so on, and that can channel a circuit around that can support a flutter. But the left atrium, until you do something to it, or until it's structurally abnormal, like in congenital heart disease, typically anomalous pulmonary venous drainage or something like that, you won't ever see a left atrial flutter, okay? So when you see these clinically, ask yourself those questions. Has the patient had ablation? Has they had surgery? Or do they have congenital heart disease? And if the answer is no, and it's not that clear sawtooth pattern, it's fib. This is flutter, and this is an isthmus-dependent type flutter. Okay. Last couple. 46-year-old man with chest pain. Okay, here's another one I see coming up very frequently, so one to watch out for. I code it out as sinus rhythm, left ventricular hypertrophy, since it meets criteria, but again, that wouldn't be the big scoring diagnosis here. The biggie would be acute pericarditis. And again, they're not trying to fool you, but they don't want you to take someone with clear ECG findings of pericarditis to the cath lab. And so they're wanting you to be able to think about that and recognize that. And the main thing about this is the ST elevation is diffuse. It's across all the precordial and inferior leads. And what's a fairly specific sign, too, is that PR depression that you see that's below the baseline. I like to look at AVR, actually, because you actually see PR segment elevation. If you draw a line across that segment there, here, the PR interval, or the PR segment, I'm sorry, is elevated. And that's a very, very sensitive and specific finding for acute pericarditis, which is what this is. But it's really the diffuse, non-coronary ST elevation, and to some extent the scenario, they may even have said, with a fever or something, that gives the game away, that they really want you to be able to distinguish this from an acute myocardial infarction or acute coronary syndrome. That's that PR segment elevation. Okay, last couple here. This is an 82-year-old man, again with a routine ECG. What do we think this shows? Okay, so here's another, not quite guaranteed, but frequent flyer. This is dextrocardia. And the way you'd think about this is, as I was saying previously, there's only two ways to get this sort of appearance with a negative P wave in 1 and AVL. One is if the leads are swapped. And that could be another thing you might see on the boards, where this is the right arm, left arm situation where the P wave vector has changed. So again, get used to looking at which direction is the P wave going in those leads first. And so one possibility could be that those two leads are switched. But then you look at the precordial R transition, and you see this opposite to what you'd expect it to be. And I would have to say that, similar to as I mentioned before, if an ECG tech could get every single lead in the wrong place, they might get this sort of picture. It'd be pretty hard to do. So it's either that or it's dextrocardia. Okay, so they're the two clues. Always look at 1 and AVL and AVR, and you can see that the P wave vector, and in this case also the QRS vector, is the wrong way. But the P wave is what gives it away, I think, more subtly. And then you ask yourself the question, well, are those two leads in the wrong place, or is the heart in the wrong place? And in this case, the heart's in the wrong place because the precordial transition is opposite to what it should be. All right, last one, and then we can break for 10 minutes before the next session or so. So let me see what you think of this one. A 77-year-old man with a routine ECG. Okay, so this is kind of a tough one. But this is what it is, sinus rhythm with dual chamber pacemaker. You know, this is one of those quote-unquote normal ECGs that's not normal, but there might be some subtle findings on it. And it's just worthwhile always scanning for some sort of electrical, in this case, pacing spike or noise or something like that, that might give you the indication. This is clearly pacing here, and if we switch off the pacemaker, you can see that the QRS morphology changes. Here it's on, here it's off. And, you know, they might just throw something like that in there, but just in your sort of mind check, look for something like that. They're certainly not going to show you complex pacing algorithms of any sort. They've never done that, and I don't think there's any reason for them to do it this year. But recognizing a ventricular pacemaker of some sort, I think is fair game, so do that. I don't know how all of you did on that, but I think these are a little bit harder than the typical examples you might see. Many of them were chosen, or I chose many of them to make or illustrate certain points. But, if you're doing okay today, you're going to be just fine. I think you're going to be just fine anyway. The main thing is do not be anxious. You know all this stuff. Yeah? It's only the gamesmanship now that you've got to get through to prove to the ABIM that you know the stuff. And you won't see anything that's out of the ordinary, out of left field. You'll see bread and butter stuff. And when you see it, it will be obvious in your face. And if you go for the big stuff and have maybe 2 or 3 big ticket items that you're going to code for, you're going to pass, okay? If you overcode and you become so anxious about every minutiae, you're still going to pass, but you might fail. All right. Good luck. Thank you very much. Bye-bye.